Well, hi, everybody. Welcome back from a most wonderful lunch. Should we do a round of applause for the lunch before we get started? So amazing. We were just talking, we're really thankful for the healthy lunch because now we don't have to worry about a postprandial dip in energy from all of you. I know you will be really engaged. So I have been really enjoying the summit thus far. We were also saying it gets bigger and better every year, and it's just a highlight of the year, really. So our panel today is on food as medicine. I'm going to give a very brief introduction to food as medicine. I think we share a lot of knowledge here today in the room, and I am sure there are more experts in food as medicine among you, and we can't wait for the questions. And then we're quickly going to go to our wonderful panelists so they can give you their perspectives. Let's see, can I change the slides or someone do the next slide? Here we go. Oh. So maybe I'll introduce myself first. So my name is Lisa Goldman Rosas. I'm a faculty member here in the Stanford School of Medicine. I am in the Department of Epidemiology and Population Health and the Department of Medicine, and I lead the Food for Health Equity Lab. And the Food for Health Equity Lab is really not me, but all of these wonderful people, some of whom are in the room, waiting, Marcella, Alethea, hi. This work takes an incredible effort by some very committed folks who are all out in the community as we speak, working with patients and doing nutrition education and delivering food. So I'm really grateful to them to be able to do this work. So let's talk a little bit about food as medicine and do some definitions. You'll notice on this slide I wrote food as medicine. You'll notice later I wrote food is medicine. So hopefully you can find yourself in one of those terminologies and decide which one you like. So what motivates food as medicine for myself and for our panelists as well starts with food insecurity. We haven't talked a ton about food insecurity today, but it refers to limited access to healthy food for a healthy life. And one of the reasons it's so important is actually it's been growing in the United States. You might think that we had an increase in food insecurity during the pandemic, but thanks to some wonderful safety net support systems, we did not. However, as a result of increased food prices and recession-type economics, we've seen an increase in food insecurity in the U.S. Nutrition insecurity builds on this notion of food insecurity and talks about the connection to health management and treatment of disease, nutrition-related chronic disease. And food and nutrition insecurity disproportionately impact minoritized communities, low-income communities, and in some cases, specific household characteristics like those with children and women as head of households. Food and nutrition insecurity we care about a lot because it impacts a number of nutrition-sensitive chronic conditions like diabetes, obesity, cardiovascular disease, and behavioral health as well. So food as medicine, the definition is the integration of food-based nutrition programs into healthcare, quite simple. And we like to think about combining the food intensity of the intervention with the acuity of the healthcare condition. So you can see at the bottom, we have our population-level nutrition programs. You might think of WIC as one of the original food as medicine programs, which is available widely to pregnant women and women with children under 5. And that, of course, is for prevention primarily or promotion of health across the life course. As we increase in intensity of the food as medicine interventions, you might think about produce prescriptions, medically supportive groceries. These might be for folks who are having a risk factor for chronic disease or managing one chronic disease where nutrition is important, all the way up to medically tailored meals, which is a more intensive form of food as medicine and might be better paired for those who are dealing with more acute conditions. We're really lucky right now in California that we have a number of policies, including our 1115 waiver that you might have heard about, which is known as CalAIM here, that allows our Medicaid dollars to be spent on food, and that helps to provide some of the funding for food as medicine in our state. We're actually one of 8 and maybe now 9 states since I made this slide that has an 1115 waiver. We also have a lot of support nationally for Food is Medicine, which excites many of us who have been doing this work prior to even being called Food is Medicine. So it's really exciting to be doing this work at this time. So we had the recent White House Conference on Hunger, Nutrition, and Health that really underscored the importance of Food is Medicine, as well as initiatives, for example, from the American Heart Association, like healthcare, what did they say? Healthcare X food? Healthcare and food. Buy food. There you go. I don't know. I'm not sure. Okay. But enough about that. Let's meet our panelists because I want you to hear from them. So we have 4 wonderful panelists who have joined us today. So first we have my colleague David. He is the executive director of Loaves and Fish's Family Kitchen, which is one of our medically tailored meal providers here locally. We have Michelle Kuppich. She is the executive director of the California Food is Medicine Coalition. We have Maya Murthy, who I have to remember has a new title now, who is the CEO of Ahara. Did I say that right? Okay, thank you. Which is a Food is Medicine provider as well. And Erika Tribett, who is with Project Open Hand. So there are a lot of definitions out there of food as medicine, and it can look different for different groups. So the first thing I'm going to do is ask each of our panelists to introduce themselves and tell us what brought them to this work, and tell us what food as medicine means to you. And I'll start over here on the left with Maya.
All right. So you can see my background is nutrition. I'm a registered dietitian with a public health background. Which means I was very traditionally trained, not so much in culturally relevant nutrition education. And so maybe this is sort of a backlash of that, coming back very full force with, wanting food as medicine to be very tied, very integrated with culturally relevant nutrition education, evidence-based practices, registered dietitians from all different backgrounds that really match the communities that we're trying to serve that have the highest rates of chronic disease. And so what food as medicine means to me, it is the word of the decade now, or the term of the decade now. But it's more than medicine. Food is health, food is life. I'm wondering if we're gonna see a switch, to food is not just medicine, it is, everything else. But it is life, it is vitality, it is our communities. And so that's what really connects me to this work.
Thanks so much, Maya, for bringing in the cultural component. I think that's really important, and I know it's important to our panelists as well. So Erika, maybe you could share a little bit about what Food is Medicine is for Project Open Hand, and maybe tell a little bit about what Project Open Hand is to those who don't know it.
Absolutely. So it's nice to be here. I'm Erika. I'm the Director of Program Design and Strategy at Project Open Hand. And we are a nonprofit organization that provides food as medicine, specifically medically tailored meal and medically tailored grocery and nutritional support interventions for those in San Francisco, Alameda, and Contra Costa counties. And we actually started our work back in 1985 during the height of the HIV/AIDS epidemic, and the goal was really to provide food that was for folks who were living with malnutrition, that were living with these conditions. Since then, we've evolved and grown into working with folks that are living with or at risk of diabetes, heart disease, and a myriad other conditions now. Involved in the work with the waiver that, the CalAIM waiver that Lisa mentioned, and so on. So all of our work is really rooted in the power of food for the prevention and management of chronic conditions. I would say that my connection, I have to go back a little bit to my connection with Project Open Hand started when I was in grad school at Cal, and I was writing my thesis on the power of food as medicine from a different perspective, from the beginning of our lives, so the first 1,000 days, and the importance of integrating food as our first medicine and bringing that to mothers prior to and during gestation and postpartum. I wrote a business plan on that, Food is Medicine, and actually used Project Open Hand as a model. And so just to add a little bit of injection of personal element here is that I think it's the first medicine, and it's our continuous medicine throughout life that we can rely on, and that we need to establish structures that allow us to use healthy food throughout the lifespan to prevent and manage chronic conditions. And I would also say from Project Open Hand's mission perspective, we say we provide meals with love. We also have a congregate meal program throughout the city of San Francisco that provides social aspects as well. And when Lisa was sharing the impact on depression and stress levels and the power of food to mitigate some of those things in populations, we really value that as well. And then also the power for redirecting, which I'm sure we'll talk about, our dollars back into the community and to our local agriculture. Food is health for our community at large through those purchasing decisions too.
Wow, amazing, Erika. You brought up so many important themes. So she talked a lot about the importance of a life course perspective when we're talking about food as medicine, touched upon why we might be seeing some of these exciting outcomes in behavioral health, and then brought up one of my favorite topics around the local food environment, which I think is really exciting, and I do hope we're going to get to those themes. So I'm going to pass it off to David to tell us a little bit more about Loaves and Fishes. And Erika mentioned medically tailored meals, as did I, and medically tailored groceries, and maybe you could make sure the audience knows what that looks like, since I know you have a commercial kitchen and know exactly what that looks like.
Yeah, hello, I'm David Hott, CEO of Loaves and Fishes, family kitchen of San Jose. There's a lot of Loaves and Fishes. We all do mission-driven work. However, we're the Loaves and Fishes of San Jose. What's wonderful about this particular space for me is that traditionally Loaves and Fishes was a soup kitchen, and it grew from 1980 to where we are today. And today the offering is that we get to provide community meals, we get to provide medically tailored meals. We're the home of the Meals on Wheels program for a portion of the contracts for Santa Clara County. We get to help to support the HIV/AIDS population in San Jose with the Jerry Larson Food Basket. And so when I came aboard to Loaves and Fishes, it was just, let's take a look at our menus. We didn't have medically tailored meals being designed at that time. So we took a look at our culinary staff and we said, why can't we make meals that could be served in a 5-star restaurant? Why can't we take a community-based program and add more nutrient-rich food ingredients in those meals? And it's just been a wonderful evolution. Then the pandemic hit. We were upwards to 1.8 million meals per year, producing that many, and then we actually deliver to 165 locations throughout Santa Clara and San Mateo County. So taking on Meals on Wheels with 190 a day, no big deal, right? That said, it definitely has been an evolution for us. I would like to say that, I could have just said, let's rewind and replay what you said about the space, the opportunity to be part of this space. And I'm so grateful to this group specifically because you're willing to talk about some things that have not been a part of this topic of the food space. For many years, decades ago, this was new, and I've read everything from Ornish, everything from Gerger, everything based on lifestyle and functional medicine. I've been able to, and we have been able to establish systems and routines within Loaves and Fishes that is taking us from the traditional soup kitchen to actual provider of these wonderful ingredients to the communities that we serve. So really wonderful to be here. If you haven't seen the latest changes at Loaves and Fishes, reach out to me. I'd be happy to connect with you.
Thanks so much, David. And now I'm excited to pass it off to Michelle for you to tell us a little more about the coalition work that you're doing.
Thank you. I'm pinch hitting today. I think there was a panelist who wasn't able to be here, and I am so grateful. Being here today has been a gift. So I'm Michelle. I am the executive director of a coalition of nonprofit organizations that provide medically tailored meals, groceries, and some produce prescriptions throughout the state of California. Our organizations, 4 of our organizations actually started during the HIV/AIDS epidemic, and I worked at Project Open Hand in the 90s, providing nutrition counseling as a registered dietitian. So that's I'm just going to say my roots in this work. We are all in the healthcare space now. So our organizations historically provided services via philanthropic funding and Ryan White funding, and all after after more treatments became effective in managing HIV as a chronic disease, our organizations began participating in research and pilots in experimenting with medically tailored meals in other populations. So this is more than a decade ago. We are now in the space where our organizations are providing these services in partnership with healthcare. So I'm in a role of advocating for community-based organizations that are providing interventions, robust interventions in the communities in which they live. Many of our organizations have sustainability projects of all ranges, including the integration of plant-forward diets. I think that's, and my wheelhouse really is the healthcare space. It's really complicated, so having these services available, particularly in California with their CalAIM program, also presents a lot of challenges, and there's also a lot of competition.
Mm-hmm. Yeah, thank you so much, Michelle. So I think we're going to get into those complexities, which I'm sure you're eager to learn about. One of the first things I want to talk about are kind of the key ingredients. We always have diet and food analogies when we're doing food as medicine. It's the best part. So we like to think about kind of 3 key ingredients for food as medicine. First, you need to have integration in the healthcare system, right? So that can mean training of healthcare personnel to do things differently. We heard a lot about that this morning in terms of education and medical providers. You need to have changes to the electronic health record so it's easy for healthcare systems to refer to food as medicine. So changes in the healthcare system I think of as kind of the first ingredient. And of course, you got to have the food, right? So you heard about some different models, and hopefully we can talk a little bit more about that, whether it's produce prescription or medically supportive or tailored groceries or medically tailored meals and so on. And then the third one that I have a bias towards that I really don't want to get left out is the nutrition education component. Of course, you can't just give people food and send them on their way. You need to give them support to know how to turn those foods into healthy, sustainable lifetime behaviors. So the first question is for Maya, because I know she shares this bias of mine as well. I was wondering if you could talk a little more about the importance of nutrition education in food as medicine.
Absolutely. This is such an interesting time because there's so much misinformation out there. You've got Joe Rogan, who has a very surprisingly large audience, talking all kinds of stuff about nutrition, nutritional science, what you should eat, what you shouldn't eat, what's in your food that you don't know about, all of that. So this is a critical time for, again, the research, the evidence-based practitioners, registered dietitians, everyone to really get behind this and talk about the right information and put the right information out there. There's a piece of nutrition education that, if you don't handle it correctly, nutrition education can come off as you are teaching something to somebody that they already know a lot about, right? Everybody in any culture, in any language, in any part of the world knows their food, and they genuinely know what they should be eating. I don't know any mother in any culture that doesn't say, eat your vegetables, eat your fruit, drink more water. So inherently, we need people and practitioners and healthcare providers to be bringing those roots up and putting out messages that resonate with these populations and not having it be a cookie cutter approach, not having it be something that you tear out of a nutrition education book, something that really reflects the plates, the bowls, the leaves, whatever people are eating off of, and really shows them that they are part of this movement. They are part of health. They are part of healthy eating. They are part of, nutritious living. So how do you do that? You can do that with nutrition education, culinary education, getting back to teaching people about basic skill building in the kitchen. How do you cut a certain piece of produce? I have a long career prior to Ahara in food banking. And one of the biggest items that doesn't move is any type of squash. And you think of butternut squash, you think of acorn squash. It is so hard to cut. I have injured myself so many times just trying to cut into a squash. So how do you conquer so many different levels of this with we need to move the squash. We have farms that are producing the squash. We want to support these farmers. It's healthy food. It is really nutritious. You've got populations that would benefit from the fiber, from the water, from all of the stuff that's in this produce. They don't know how to use it. They don't know what it tastes like. How do I season it in a way that my kids will eat it? So there's so many layers and so many opportunities here to really make that connection. That's really what we do at Ahara, is really put that content out there, connect registered dietitians across hundreds of different languages, hundreds of different cultures, and really connecting them with the people that have highest rates of these diseases, and can show them that they are part of this equation and welcome them into the kitchen and get them into, cooking the food that they now have better access to, hopefully through these waivers, through the Cal-AIM and 1115 waivers.
Yeah, thank you so much, Maya. I mean, I really appreciate the folks on this panel, because I think a lot of times nutrition education gets a bad reputation for telling you what you shouldn't eat and assuming that you don't know a lot about nutrition. And Christopher often says, I love being a nutrition researcher because everybody's an expert in food. I think sometimes he says that sarcastically. But it is really exciting to do nutrition education in communities that bring such different perspectives and varied ideas about food, but we have to understand they all start with a lot of knowledge about food because they're eating every day. And I think the theme of cultural tailoring and making sure that food is able to be incorporated into family and culture no matter what is so important. Okay, so we talked a little bit about that ingredient of nutrition education, which I think is so important. I'm going to ask Erika to talk a little bit about the food component. So one thing we've been talking about today is climate change and planetary diets. So maybe you could help us make the connection between food as medicine and planetary climate-friendly diets.
Absolutely. So I think the most obvious thing to say is that food as medicine interventions across the pyramid that Lisa shared with us are all in the interest of bringing nutrient-dense foods in whatever package it's coming in. If it's a produce box, if it's a full grocery box, if it's a medically tailored meal that has more specific specifications around it, these are all designed to bring healthier planetary health and human health going together into folks' diets at a population level. So I think from a fundamental standpoint, food as medicine can be, if designed well, designed to naturally support planetary health and in favor of supporting a healthy climate. So that's one aspect. I think one thing too for food as medicine that is related to nutrition education is we want people to want to consume this food. We want people to know how to use the food, reducing waste, which is another way that we can impact planetary health through food as medicine interventions. What we need to do also is to craft meals, to David's point, that are delicious. We need to make sure that we are asking our clients, to Maya's point about working with our client populations, culturally and otherwise, what do you enjoy eating? How do we need to design a menu that is not only specified medically to help you support a chronic condition you may be living with or prevent one, but how do we make sure you want to keep coming back to it again and again and again, and then create it on your own? So those are a couple of ways. When we're thinking about the supply chain at Project Open Hand, I'll just mention that as an example, we recently were awarded in 2022 a Gus Schumacher Nutrition Incentive Program, aka GUSNIP, grant to begin to build in locally sourced, seasonal, and regeneratively sourced items for our grocery program. We started with our whole foods that were not processed in the kitchen. That was the easiest path for us initially, but it allowed us to start work of building relationships with local aggregators, with food hubs, and bring in these local products. We're now working directly with a couple of farms, Oya Organics and J Leaf down in Hollister, and so finding pathways that we start to align values with the foods that we're sourcing that are also delicious. And now we're continuing work in the next couple of years with the YOLO Food Hub as well, and so just finding ways to learn about what's going to provide a seasonal local opportunity for sourcing and values-based purchasing to create those delicious meals that we are setting an example with for the populations we're working with.
That is so amazing. So when you talk about climate change and planetary health, we're not just talking about the types of foods we're promoting, but you'll see that we're really focused on sourcing the food. So it's not just about getting people food, but it's about thinking about where it comes from and how it's grown. So that was totally awesome. So we started this talking a little bit about health equity, right? So there's populations like minoritized communities that are disproportionately impacted by both food insecurity, but also diet-related chronic conditions. And as you know, we talked about the three ingredients being the nutrition education, the food, and then the integration in the healthcare sector. I want to ask David, to really affect the maximum change in health equity, what do you think needs to be done? And it's not fair because David and I spent all day on Tuesday talking about this already, so I know he has a lot to say. What do you think needs to be done to really scale food as medicine for it to be successful, county-wide, statewide? What are your thoughts?
Thank you. Great question. Collaboration, sharing of ideas, talking about creative ways to collaborate and do the work together. It takes a village. I know that sounds cliche. However, if organizations come together and share best practices and talk about real deal things that are happening for them, I think it's a way to share ideas and then build out programs. I have to go back to the sustainability piece as well. We decided that we were going to reduce food waste, and we bought a biodigester. And now we can create organics we can take organics and process those organics in 24 to 36 hours, and then use that material in our garden, in our organic garden. So what does that have to do with answering the question? I think it's everything. We share ideas. In the space, being new to the space, we were the fortunate organization that helped to integrate these 3 new programs in Loaves and Fishes from our wonderful friends over at the Health Trust. So they had already built out these programs. Now we're a new program to this space, sharing ideas about menu options, sharing ideas about how, in fact, billing works for an organization that's not doing the activity at present, but wants to build it out to be of support to the communities that we serve. Being honest about what may be an opportunity to be fixed. Funding is, of course, that terrible F word. Funding, right? That is definitely a challenge in the space, especially if you're a smaller-ish nonprofit who's trying to build out the program that we're describing to be of support to the communities that we serve. So everybody has something to add as it relates to the conversation in this space. And what I've been so happy about in that meeting that you brought us together is to talk about real-world opportunities in this space and how we can work together to solve the problems. And it's been a wonderful, wonderful experience. I'm turning more white. I'm losing more hair. However, I refer to myself as a hippie with short hair anyway, so I'll just cut it all off. So thanks.
Thank you, David. Yeah, we've learned so much from you and the incredible pivoting your organization has done to grow and fit the need in our local community. So you mentioned funding and policy, which of course are really big issues, and if Michelle knows this question is coming to her. So we talked earlier about kind of the big P policy we're talking about, so policies like CalAIM, our 1115 waivers that allow healthcare dollars to be spent on food, which is so exciting, but also that little p, like policies within the clinic that are going to facilitate patients getting more and more access. So Michelle, can you walk us through some of those big P and little p policy changes that you think will support food as medicine?
Yeah, thank you. So in terms of the big P, I want to refer to legislative advocacy. And Lisa, in your introduction, you highlighted food insecurity. And food insecurity is a health harm with a price tag. There's also something called nutrition security, which is about the access and availability to food that really promotes health and allows you to manage your health conditions. I want to just remind everyone that the Farm Bill, which was actually mentioned earlier, has 12, it's large, it has 12 parts, but there's 2 very important pieces, actually more than 2 important pieces relevant to this audience. And one is the Supplemental Nutrition Assistance Program, so SNAP, formerly known as food stamps and known as CalFresh in California. It is so important that we protect and fund SNAP for supporting baseline food insecurity, reducing food insecurity. And I'm hoping that we get to a place where that the CalFresh and SNAP program really is used for healthy foods, maybe similar to the WIC program. I know that autonomy has always been the strongest argument, but maybe we're at a place now where we could have that conversation and see that change. The other piece that is important in the Farm Bill is GusNIP, which Erika mentioned, and that, again, it tests. There are a few aims of that program which look at the impact of produce prescription and produce on healthcare, on consumption, on the impact of health, and I think on costs. There's three things. Mm-hmm. So on a federal level, I think the Farm Bill. There are also, Lisa, you've mentioned I want to say something that may or may not be obvious to people, and that is the Medicare and Medicaid. There are federal regulations preventing healthcare dollars from being spent on food. And so there are different levers which are used to get around that. And Lisa, you mentioned in California has had several waivers that they have built on, and we now have something called in lieu of services that enables California Medicaid to allocate healthcare dollars for other services, including medically supported food and nutrition. So I'll come back to that in just a minute, but expanding on that, there are other levers. And so in Medicare Advantage, which is private Medicare, there are some mechanisms that enable payments for food and I'm going to say it should be healthy, not always, in that program, but there is not any mechanism in original Medicare. And so to go back to the Big P policy, there is federal legislation that would pay for a pilot in the Medicare program to test medically tailored meal interventions. So those are some examples, not all of them, of federal legislative efforts to advance food as medicine within healthcare. In terms of California, this past year there was a bill, AB 1975, that would make the medically supportive food nutrition, it's a catch-all phrase for a lot of interventions, a permanent benefit after this in lieu of services waiver ends. So we'll see another version of that bill coming next year, perhaps maybe an assembly version and a Senate, California Senate. But those are examples of at our state level that are working to advance the integration of these services into healthcare. I'm going to go to I just want to comment on the existing in lieu of services waiver. Right now, it is a great opportunity, and it's also very challenging. To get a little nerdy on you, that there are the services must have a reasonable expectation that they're a substitution for other high-cost utilization. So right now, medically tailored meals, medically supported food nutrition interventions are positioned to really reduce healthcare costs, which is a tall order. And so they're being examined on their impact on ER visits and hospitalizations. I'm not saying that shouldn't be done, but I think it's really important to reframe the evaluation and for us to think hard about the intent of these interventions, especially if we want them to be longer term. On the smaller P side, you have implementation of policy. So that can happen at our Department of Healthcare Services. And so the guidance that is set out by the state is really important because all of our private health plans in California that are administering these programs set guidelines and policies. So I just want to mention that you have, at a very high level, good policies, and this small policy stuff is where the rubber meets the road. What populations have access to the services? How long can those interventions, will they be covered? And so we are doing a lot of advocacy in this space to help ensure that the populations that will benefit from these interventions the most, whether it be people with specific chronic conditions, that the interventions are actually positioned to have an impact on people's health. So thank you. That was very long.
That was perfect. I mean, what Michelle is alluding to is we really do have an incredible challenge in front of us, and that's going to be one of my next questions to the panelists. We've been very hopeful and excited, but there are a number of challenges in our way. So although we have the funding from CalAIM, as Michelle alluded to, we have 58 counties in California, I think something like 24 health plans, and 15 million Medicaid members or Medi-Cal members here in California. The last time I looked at the website for CalAIM, it was something like 12,000 patients had received medically tailored meals or medically supportive nutrition. I have to imagine that there is a huge gap between who's eligible and who's actually getting it. So this needs to get to every county, which means every health plan has to know how to deliver this to our millions of members in California who likely are eligible, even if you think only half or 2/3 of those patients would be eligible for medically supportive nutrition. So let's talk about like the number one challenge you see for Food is Medicine now. And Michelle raised her finger, which I know means she has a little idea. So I'm going to let her go first to add on to that.
Well, so I wanted to say if I could add on to something about the small p level, but it actually is kind of an answer to your question, is that one of the challenges we've had in California is a lack of strong nutrition standards for these interventions. And so I think it's really important that we have a high standard, not bureaucratic, but that actually there are a lot of players in this space, and so that the interventions that your taxpayer dollars are paying for and what people are receiving is food that's actually healthy, derived, and people want to eat it. I mean, it's so important, and so I think that is a challenge. It's also a policy-related issue, and we'll continue to make progress on this. But I would say that is the other piece is the efforts to scale these services, I think presents a lot of opportunities and challenges because I'm going to answer this question from a healthcare context, is that in our CalAIM program, it's the private Medicaid program, or Medicaid managed care programs that are rolling out these services and paying for them. And so they have to manage their budgets. There's definitely a cost piece of this. And so we want to really we want them to pay for high quality interventions. And it's really hard to make sometimes the argument about local, sustainable, organic, because although it may be important, it's not quite the right financial incentive for them. So I would love to see the state of California actually incentivize these health plans to ensure that they're actually promoting a diversity of players and choice for people, and at the same time ensuring that all of the other system level things are in alignment.
I think that's so well said and couldn't agree more. If we don't make standards and provide resources for the quality of foods that we want to be providing, there'll be a race to the bottom of whatever is the most affordable, and that's a risk for sure for Food is Medicine. So I'm glad you brought that up. Who wants to take the next one for kind of biggest challenge you see right now?
I will.
David? Okay.
I think to consider a smaller nonprofit having to put resources into this effort and then waiting for that period of time for reimbursement, right? So if a nonprofit has $50 million in the bank, that's a different story. However, if terms are made consistent between payers, and you do a net 15 or a net 30 or a net 45, and then you streamline the process and submissions are done consistently, it helps some of the smaller-ish nonprofits to get involved in the space. There's just not consistency. And for a smaller nonprofit to get into the space, the outlay to try to get into the space to benefit from helping to support the clients, patients, the community at large, it's difficult, right? So, and that's a real challenge at times. I know for our organization, we're new to healthcare, right? We're new to billing. We have the systems in place. It'll cost us $220,000 to build out a Salesforce system, right? To someone who has a lot of money, that's not a lot of money. We're though a small-ish nonprofit, right? So I think that many of the nonprofits that I talk to struggle with that a bit as well. If I have to wait for 6 months to be reimbursed for a service that we've provided, that makes it more challenging to continue to expand on the offering and then to scale the model. Because what I've heard from some insurance companies is they want to be able to depend on the fact that if they make that commitment and then they ask us to take on more clients, can we deliver? And the answer is yes, we can, as long as we're provided with that reimbursement in a timely manner. So I think there's some work to be done there, especially for some of the nonprofits that are just beginning in the space.
Absolutely. I think Erika talked a little bit about before about supporting our local food environment, right? So there's nonprofits, also farms, who are willing to provide food as medicine. Farms traditionally don't bill Medi-Cal for their services, right? They think of it as food that people purchase. And I think on Tuesday, the meeting I alluded to that David was at, we listed something like 19 different administrative processes that a nonprofit or a farm would have to become experts in order to provide food as medicine. And typically, these are not things that you're doing already. This would be new things that you would have to take on.
And these were leaders in the space, right? And I loved the exercise. Put a green, put a yellow, put a red, right? How comfortable were we with being able to commit to each one of these elements that she discussed? You'd be surprised how many individual organizations struggle with whether or not they even are able to do what is being asked and required. Do they have the resources today? Do they feel like they even want to get involved in that activity? So it was a wonderful exercise for all of us to see and observe how we were all, and it goes back to what we talked about earlier, the collaborative effort. So thank you for putting that together.
Absolutely. All right, Erika or Maya, you want to share a challenge you see?
I can build on what Michelle and David already mentioned by just saying that we have a great example right now at Project Open Hand that I'm sure other organizations are experiencing. And that is that, Michelle, you can correct my number if I'm wrong, but I did hear from our client services team that one of these health plans, San Francisco Health Plan, to your point of wanting to have a greater reach, is projecting around 40,000 additional folks that would be eligible for food as medicine program. It's an estimate, but that's something that we would see coming through to us as one of the primary contractors for medically tailored meals, medically tailored groceries, and RD support through Calium Community Supports. And we do not have the capacity to do that right now. And so one of the things that I really think, two things. One is assessing medical appropriateness. We have food as medicine programs, as a reminder, that are across that pyramid. And so we need to utilize our team of RDs and the experts in the field to understand who is most appropriate for which type of service and who is going to benefit from which level of service at which point in time. So right place, right time, right population. I think that's a key piece that we need to have cognizance on. And then also related to that is continuing to build deeper partnerships between organizations that are addressing different levels of these pyramids, having very clear understanding of what the services are they're providing, who they're most appropriate for, how to access them, and when appropriate, advocating for them being rolled into being contractors with health plans and being available for the community so that we don't have everyone being shuttled to one or a few when they can't be, and also it's not appropriate.
Not appropriate, absolutely. I think we have our last closing comment from Maya, and we have time, Christopher, to open up for questions after? Yes, okay, great. Yeah. So Maya, you want to close us out with kind of a challenge you see going forward?
I mean, there's many, but I think Michelle called out the competition in the space, and I think now is the time we all just need to collaborate more, I think, across organizational lines, across nonprofit, for-profit, healthcare, health plans, health providers. Everyone involved just needs to come together and figure out how do we actually build this together. We are talking about integrating the food system into the healthcare system. That is huge. That is not something any one person, one system, one entity can take on. So how do we work together to make that happen? And also putting a ton of weight and pressure on particularly nonprofits to figure it all out and to be the, one-size-fits-all model for doing it is really unrealistic. Being in the nonprofit space for so long in food banking, the healthcare space is very scary. Figuring out, even the research space is very scary. How do I prove this model? Otherwise, I'm not going to get funded for it, next year. There's so much pressure. So how do we all work together and deliver our assets to the table, all while bringing the community into the fold as well to figure out what should these programs look like? That is what we need to be doing. So I think that's the biggest challenge, but that is where the biggest potential is, and that's actually where we're gonna move this forward into something that's sustainable and able to be held up on its own and doesn't need to keep being put out by waivers. And yeah, that's what I think.
Absolutely. We've even heard recently about kind of the different cultures in the two organizations. Community-based organizations and nonprofits have very different cultures from healthcare organizations, and bringing them together means making those bridges. So can we open it up to the audience? 2 questions?
2 or 3.
2 or 3? Okay, great.
Not statements, questions.
Questions for our wonderful panelists, and Jennifer has a microphone.
And microphone. Please ask for a mic if you'd like one.
Yeah, go ahead.
All right, good afternoon. So I have a question. You've all touched on scale, but I'm wondering, when I look at some of the providers locally with the medical waiver, we have companies from Georgia shipping like frozen boxes, 14 meals a week. I won't name any name. And then we have small companies that are trying to really make it work, and without scale, it's really hard right now. So how do we balance being in California? It's California money to support organizations that are local. And the second part to my question is, do you think that there's something possible to do with Micro Enterprise Home Operation Kitchen, and training folks to provide medically supportive meal within their neighborhood?
Oh my God, you are singing my tune. Okay, go for it.
I would love to. Yes, and, right? We just built a kitchen. It'll be in service next week. So it's a 6,200 square foot commercial kitchen that we can teach people to fish, right? So we'll have a culinary institute in that kitchen. We'll teach them skills so that, in fact, not only are we providing meals, we can also do a health coaching type idea of helping them with ingredients. To purchase ingredients for a plant-based pantry is 3 or 4 times as expensive as it is to do a traditional pantry, right? So to answer your question, yes, and I think it goes back to the root, and that is we need to collaborate. Because there are others that are doing good work in the space, we can learn from them. If we're willing to share, we don't do everything as well as they may. And you also touched a nerve for me. Why is it going out of California? I'm a California kid. I grew up in Cupertino. I wanted to stay here, right? And I get to feed my people here. And so I think it's very important that we in this space, and we talk about this, we in this space work together. So I hope that helps answer your question.
Could I just add on one thing to that? I think evaluation is something we have not discussed here, and I think we need a little bit more transparency in this space. There are Food is Medicine Coalition does have nutrition standards for medically tailored meals, but to answer the question about why meals are being shipped from Georgia, I think has a lot to do with price. And so the value proposition for Food is Medicine providers, and I can speak to our organizations which produce meals that are adhere to standards and informed by guidelines and requirements, transparency. Also, there needs to be, there should be some evidence that people are consuming the meals. So I think client satisfaction, all this is incredible. That is so important, because if we're doing all of this and the meals are ending up in the waste basket, we talked about that this morning. But the value proposition, we need to continue to develop the value proposition for local community-based, and that is, I think, a combination of both nutritional quality as well as connection with healthcare. So we are doubling down on our connection with local healthcare providers in that relationship, because most people need more than 12 weeks to change behavior, move the needle on important markers of health, and changing lifestyle permanently. So there's a very strong economic one that we need to continue to build. But whoever made that statement, I just want to mention that a lot of what our California Medicaid program is covering is from out-of-state providers. Meals are being driven from Florida, shipped from Georgia, from Nevada, and other places. So.
Yeah, and for those of you who are interested in doing research in this space, Michelle just gave you some really good clues about how to design your research to be policy relevant if this is something you want to get involved in. So thank you for those. Yeah, go for it, Erika.
Can I add on to that?
Only if Christopher lets you.
Well,
he's in charge.
Mine's related to, instead of having to stand up here for a minute. So I'll just say, as coming from Project Open Hand and a representative of California Food is Medicine coalitions, one thing that we really want to see more of is equitable involvement in research that can build the case for this work and also shine a light on where we need to do better. So if anyone in this room, I know Christopher is heavily engaged in the work right now through the American Heart Association initiative. If others in the room are interested in partnering or chatting more, we'd love to talk more.
That is a perfect end to the panel.
We have one more.
Oh, one more? Sorry.
Yeah,
good. Go ahead.
Yeah, I love this conversation, and because I kind of actually started my startup trying to make it happen as a grocery as a medicine thing. So wonder how much those kind of movement or any regulations on that, how far is it going here? I would like to ask.
Like how far is the food is
Yeah.
medicine being spread here locally?
Yes, or like a grocery. Do you think there will be like any kind of regulations on that, or
I think there's an open and wide opportunity. I think that events like this help to carry on the conversations after this event. So I think it can be scaled. I think that there's definitely enough participants, clients that can be supported with this activity. And food becomes cells. Cells grow the body, right? And so I hope I'm answering your question. I think we have a lot of opportunity still. However, I'm super optimistic. Like, we keep doing things that we're doing like we're doing today, we can build out such great solutions, because at the end of the day, I'm not going to stop. I'll go find the money, because people need food. They need to be supported, and it can help their health outcomes. So I hope that helps provide an answer.
Thank you very much. Yeah, I want to talk more later on, yes.
All right, well, I hope you will join me in thanking these wonderful panelists for their time.